I may introduce Prof. Dr. Alamuddin. Thank you.
Thank you, Dr. Rasha.
Muhammad, please proceed.
دكتور خالد.
ايوه،
ازيك يا دكتور خالد؟
اهلا وسهلا.
محمد علم الدين.
Dr. Muhammad Alam, please proceed and introduce the session.
Yes.
Assalamu alaikum everyone. It's my pleasure to join Ain Shams annual conference and my pleasure to meet my friends online, Dr. Khalid Naguib, Dr. Muhammad Yassin, and it's my pleasure to introduce Dr. Muhammad Basyouni. He will speak about the role of treatment of RCC beyond the first line. Please, Dr. Muhammad, go ahead.
Hello everybody. I would like to thank the organizing committee of our conference, and also I would like to thank Elsevier Egypt for hosting this symposium under the title of Management of Metastatic Colorectal Cancer Beyond the Second Line. Over the last decades, all trials done to improve the response of treatment, the response of the tumor to the treatment, to be reflected in the improvement of overall survival in first line, started by 5-fluorouracil and vinorelbine analogs, followed by addition of irinotecan and oxaliplatin, then the addition of the targeted therapy either targeting epidermal growth factor receptors or vascular endothelial growth factor receptors. After the second line of treatment, many patients are candidates for further treatment, and a significant number of patients with metastatic colorectal cancer are able and willing to receive more treatment. Patients received the third line of treatment in the US registry were 28%, while in FIRE 3 trial they were 38%. Despite advances, the prognosis of metastatic colorectal cancer patient pre-treated with all available agents is poor, and there is a high unmet need for a new treatment. The goal of the treatment differ with the line of the therapy. As in the adjuvant treatment, the main goal is the cure, which differ from that of maximal tumor response and durable disease control, which are the main goals of the first and the second line, which also differ from the durable disease control, maintenance of quality of life, and palliation, which are the main goals of the third line and the subsequent line. We must remember this slide very good and very well, because the main aim of the third line and subsequent therapy are the quality of life. And this will help us in the decision to choose the drug or the agent to be used in this line. Before the era of new approved drugs and the era of immune therapy, after failure of 2 lines of treatment, we have no option except repeated administration of treatment regimen or single drug the patient received before. If the patient has progression on this agent, it is called the re-challenge. But if the patient did not show any progression on this treatment, it is called reintroduction. This is a snapshot of the third and fourth line treatment for metastatic colorectal cancer, 1814, retrospective real-world data for metastatic colorectal cancer. They found that in the third line patient, approximately 40% of molecules administered have been used in previous line of treatment. In the fourth line patient, 67% of molecule administered have been used in the previous line. One of the most important factors to choose this drug is the response to this agent and the duration of response. In practice, a longer interval length before re-challenging with the anti-epidermal growth factor receptors in prior responder improve outcome. And this finding support the introduction of an approved agent such as trifluorouridine, tibiracil, or regorafenib beyond this second line before any re-challenge in patients with metastatic colorectal cancer who have failed second line treatment. This finding was the result of other trial reflected on many guidelines. One of them NCCN guidelines, which recommend regorafenib or Lonsurf beyond the second line. We'll start with regorafenib, which is firstly approved. It not only inhibits the vascular endothelial, the 3 vascular endothelial growth factors pathway, but also inhibit other factors like c-KIT and RET, TIE2 and BRAF. Regorafenib approved based on 2 phase 3 studies, correct and concur. In both studies, the patient character and the disease character are the same, with the difference in the concur they enrolled only Asian patient. The patient randomized 2-to-1 with regorafenib plus best supportive care versus placebo plus best supportive care. Here, the median overall survival, in both studies, the 2 curves are started separately and continue as it is over the time, with median overall survival in 6.4 months for Rego versus 5 months for placebo, with hazard ratio 0.77, which was statistically significant in correct study. While in concur study, the median overall survival was 8.8 months for Rego versus 6.3 months in placebo arm, with hazard ratio 0.55, which was statistically significant. But Rego has high incidence of adverse events. The most frequent were hand and foot syndrome, fatigue, diarrhea, hypertension, and rash dysphonia. And the summary of product suggests dose modification and the measure in response to hand, foot, skin reaction. Regorafenib is associated with toxicity concern in frail patients. Well, now we will move to the secondary approved drug, which is trifluorouridine tibiracil, which is called Lonsurf, and it is recommended in NCCN, ISMO, and NICE guideline. It is indicated for the treatment of adult patients with metastatic colorectal cancer who have been previously treated with or are not considered the candidate for available therapies. It has 2 molecules, trifluorouridine, which is a nucleoside analog, which incorporated into the replicating DNA strand, resulting in inhibition of the DNA synthesis and cell proliferation. The other molecule is tibiracil. It inhibits thymidine phosphorylase, which is the enzyme responsible for breakdown of the active trifluorouridine component, which result in DNA dysfunction, prevention of cell proliferation, and anti-tumor activity. Also, thymidine phosphorylase play an important role in the endothelial cell migration and angiogenesis of malignant cells. This mechanism of action is completely different from that of 5-fluorouracil or other prodrug, which inhibit only thymidylate synthase, result only into DNA synthesis inhibition. This drug approved based on phase 2 and 3 studies, JAPIC trial, RECOURSE, and TERRA. While that is the RECONNECT study, it is ongoing phase 3 study. Both phase 2 and the phase 3 study, patient character and disease character are the same, with the exception of the TERRA study, in which they are enrolled Asian population, and also in the phase 3 study, RECOURSE and TERRA, patient allowed with ECOG performance status 0 or 1, while in the phase 2 study, they allowed enrollment up to ECOG performance score 2. We take a RECOURSE as example of one of the global randomized double-blind placebo-controlled phase 3 trial to assess the efficacy and safety of Lonsurf in patients with metastatic colorectal cancer. About 800 patients randomized 2-to-1, Lonsurf plus best supportive care versus placebo plus best supportive care. The treatment continue until progression, intolerable toxicity, or patient refusal, with primary endpoint overall survival and the key secondary endpoint PFS and safety. Patients enrolled in this study with ECOG 0 to 1 received at least 2 prior treatment regimen of standard chemotherapy. Any agent of chemotherapy allowed, even regorafenib, with adequate bone marrow, liver, and renal function. And this is the baseline demographic and disease characteristics, where well balanced between the two groups, including age, sex, race, geographic region, ECOG performance status, primary sites, KRAS mutation, the time between diagnosis of metastasis and randomization, less than 18 months or more than 18 months, number of prior regimen, all the drug used before, and as we said before, there is about 37 patients received regorafenib, and high percentage of patients who was refractory to fluoropyrimidine, and this is explained by the different mechanism of the two agents. As overall survival, driver overall survival analysis shows that 1.8 months is median overall survival benefit with Lonsurf versus placebo with hazard ratio 0.68, which was statistically significant. Secondary overall survival analysis shows 2 months is median overall survival benefit, 7.2 months with placebo with Lonsurf versus 5.2 months with placebo, with 31 reduction in the risk of death with Lonsurf versus placebo with hazard ratio 0.69, which was statistically significant. In progression-free survival, the two curves also separated and continue all over the time, with median progression-free survival is 2 months with Lonsurf versus 1.7 months with placebo, with 52% reduction in the risk of progression with Lonsurf versus placebo, with hazard ratio 0.48, which was statistically significant. 44% of patients treated with Lonsurf and had their disease controlled versus 16% with placebo. As preservation of performance status, which is one of the most important endpoint, trifluorouridine tibiracil significantly prolongs the median time to performance status deterioration versus placebo, with median time to performance status 2 or more from baseline is 5.7 months with Lonsurf versus 4 months with placebo, with 34% reduction in the risk of deterioration to a median time to performance status 2 or more with Lonsurf versus placebo, with hazard ratio 0.66, which was statistically significant. This is exploratory post-hoc analysis of the effect of Lonsurf in patient treated in recourse study by prognostic factor. Patients enrolled in this study classified according to the prognostic characteristic into good, best, and poor, based on low tumor burden and aggressiveness of the disease, with 1 to 2 metastases in the good and best group versus 3 or more in the poor group, and the time since the diagnosis of the first metastasis, which is 18 months or more in the good and the best group versus less than 18 months in the poor group. The difference between good and the best is only the absence of liver metastasis in the best group. As a summary, Lonsurf efficacy was demonstrated in all subgroups and more pronounced in patients with good prognostic characteristics. And here we can find some question or suggestion to use or limit the usage of Lonsurf in this patient with good prognostic characteristic only. But we must use it in all 3 groups as the performance settings allow. Why? For 2 reasons. The first reason is the administration of Lonsurf maintain and preserve the performance status in all groups. And also, as the second reason, is that if we look for this figure in the PFS in the placebo arm, we find it is almost the same in the 3 groups, and the prolongation of PFS result from the administration of Lonsurf. 89% of Lonsurf patients with good prognostic characteristics and 78% of Lonsurf patients with poor prognostic characteristic remained at performance status 0 to 1 at treatment discontinuation. This is the main side effects and the adverse event with Lonsurf, and you find that for confirmation in the patient with good and poor prognostic characteristics still at performance status 0 to 1 at treatment discontinuation, making them eligible for subsequent therapies. And the main side effect or adverse event with Lonsurf is nausea, fatigue, anemia, leukopenia, which occur in about 30% of patients. Overall incidence of grade 3 or more toxicity with Lonsurf was 69% versus 52% with placebo. 4% of patients stopped taking Lonsurf due to adverse event versus 2 with placebo. These tables show the comparison of the side effect between Lonsurf and the regorafenib or Stivarga. And we find that there is a difference in the main side effects, and the different safety profile of trifluorouridine tipiracil and the regorafenib will influence the choice treatment in third line. And here we can ask, can we start with the Rego or Lonsurf? My opinion, we must start with Lonsurf. Why? For 2 reasons. The first one is depending on the result of the previous studies, and also here for this side effects. The main side effect in Lonsurf is mainly hematological toxicity or side effects, which can be treated either as prophylaxis or even after occurrence treated by bone marrow stimulating factor. While in the regorafenib, the main side effect hand and foot syndrome. And in our country, in Egypt, we saw it in high grade 3 or 4, which is associated with severe skin reaction and the pain, which limit the activity of the patient and reflected in the quality of life, which is the main goal of the treatment in these lines. The second reason is that this usage of the trifluorouridine, the maintenance of performance status is good in Lonsurf, and so that we can use subsequent treatment. Another cause for starting with Lonsurf, we start with the full dose, 35 milligram per square meter, and so that we have a wide range of reduction of the doses to 30, 25, or 20 milligram. But in regorafenib in our country, no one can start with the full dose 160, so we start with 120 or 80 And this gives us a narrow scale for dose reduction, as we cannot reduce the dose below 80 milligram. We will not stop at this point, but there is a trial to increase the efficacy of Lonsurf by addition of beva, and this Danish phase 2 trial, which shows that Lonsurf plus beva associated with significant and clinically relevant improvement in progression-free survival with tolerable toxicity. Also, another study is phase 3 ongoing study, addition of beva to the Lonsurf for first-line metastatic non-resectable colorectal cancer, Lonsurf plus beva compared with capecitabine plus beva. As a conclusion or take-home message, the standard of care for the third-line treatment in metastatic colorectal cancer is regorafenib or Lonsurf. Lonsurf and Rigo have compatible efficacy, with Lonsurf has more favorable safety. Introduction of an approved agent such as Lonsurf or Rigo beyond the second line before any re-challenge in patients with metastatic colorectal who have failed second-line treatment. Lonsurf mechanism of action is different than other 5-fluoro-based fluoropyrimidine. Neutropenia severity during first Lonsurf treatment cycle associated with better efficacy and survival. Treatment with trifluorouridine tibiracil showed benefit in all patients with prognostic characteristics based to good and poor. Lonsurf shows a better ACOG performance status preservation versus placebo, even in patients with poor prognostic characteristics. Third-line treatment with Lonsurf plus beva show promising PFS and could be practice-changing if compared to Lonsurf alone or Rigo. Drug combination is under investigation to improve outcome. Thank you.
Thank you, Dr. Mohammed, for this comprehensive and informative presentation about the role of Lonsurf at third-line treatment in metastatic colorectal cancer. And due to short of time, we will close the session at this point. Thank you.